we're hosting this call today on World Kidney Day, which we thought was appropriate. For World Kidney Day today, the focus is on chronic kidney disease to raise awareness about this major public health issue and epidemic, so we thought it was very appropriate for this day. We'll be talking about our strategic blueprint for advancing quality care, a program we've been working on for a year now. This program follows our quality initiative we had last year called our PEAK initiative, the Performance, Excellence, and Accountability in Kidney Care Quality, which at the conclusion of that 2-year campaign, we saw a reduction in mortality for the first year of 15%. And our partner at Brown University. We have 3 guest speakers today that represent healthcare and medical professionals from Kidney Care Partners organizations that were chosen among their peers from the Blueprint Steering Committee. The steering committee is made up with professionals from the American Kidney Fund, DaVita, Fresenius, Renal Physicians Association, Dialysis Clinics Incorporated, the National Kidney Foundation, the American Nephrology Nurses Association, and Amgen. Of the steering committee participants, we have our 3 experts today who will walk through our slide presentation. That consists of Dr. Ed Jones, who is chief of the renal section at Chestnut Hill Hospital in Philadelphia, and he's a clinical professor of medicine at Temple Hospital. Also president of Delaware Valley Nephrology. He's past president of the Renal Physicians Association, and he's our current chair of Kidney Care Partners. Also joining us will be Gail Wick. She is the current chair of the American Kidney Fund. She has held senior positions with large providers as head of nursing and quality programs, and she's also served she's past president of the American Nephrology Nurses Association. And our last speaker from our steering committee is Dr. Alan Nisenson. He's the chief medical officer of DaVita and is an emeritus professor of medicine at the David Geffen School of Medicine at UCLA, where he served as director of the dialysis program and associate dean there. He's also former president of the Renal Physicians Association and has worked very closely with CMS on issues related to care, delivery, quality, financing for patients with chronic illnesses and other related areas. So at this point, I would like to turn this over to Dr. Jones, and thank you again for joining us today. Dr. Jones?
Thank you, John. I appreciate that. Well, again, my name's Ed Jones. I am a nephrologist from the Philadelphia area and practice nephrology, taking care of a number of patients with chronic kidney disease on dialysis. And as chair of Kidney Care Partners, it is a pleasure to present with what we think, who've been working with this for the last year, is potentially a game-changing document if utilized appropriately.
Great.
KCP has been in existence since May of 2003. It clearly represents the entire community, including, as John has mentioned, patients and patient advocates, dialysis facilities and providers, physicians and nurses, and pharmaceutical and device manufacturers who've come together as the voice of the entire kidney care community. KCP mission is to ensure that patients with chronic kidney disease receive optimal care, that they're able to live quality lives. Dialysis care needs to be accessible as needed, and importantly, that research and development lead to enhanced therapies and innovative products that can be utilized, again, for patient care. Now, Kidney Care Partners is a unique organization. It indeed has been at the quality front for a number of years. In the beginning, we formulated what is now called Kidney Care Quality Alliance, which is a unique alliance and the only one that's available within our space. Its purpose was to develop and test performance measures for National Quality Forum endorsement, and it continues to shepherd those measurements even today. Importantly, John mentioned this, the community got together a number of years ago and put together its own voluntary goals initiative that we called Performance Accountability in Kidney Care, or PEAK. This effort brought best practices to the forefront and were utilized by many within our communities. And indeed, the first-year mortality rate through June of 2013 showed a 14.5% reduction, which is a remarkable feat of it. Early last year, Kidney Care Partners, as it began to look at its quality agenda, realized that there was something missing, that we weren't just about making measures, but what was necessary was a strategic blueprint that indeed stand as a roadmap on key actions that, if taken through collaboration and working together, can significantly improve kidney care quality. Up until this point, there was no such blueprint, and when you look around medicine today, there are very few of these type guideposts. The community really has done a great job, as I mentioned, mortality rates falling and a number of other interventions that have occurred. But our feeling was that it was necessary to have this strategic blueprint that would identify essential areas for improvement. This project began early in 2013 and was overseen by a blueprint steering committee, and John mentioned those, and my other friends on the line who will be talking were part of this steering committee. And it represented, again, the entire community, whether it was the renal physicians, the nurses, the patients, the American Society of Nephrology, the providers, got together to put this document together. It was a multi-stakeholder consensus report. It initially started by doing an extensive literature review, which is outlined in the blueprint itself. There were then semi-structured interviews with KCP members. We had an outstanding day of a summit where we had in-person experts and content individuals who came together to put together the document. We then had internal reviews amongst the members of KCP. And finally, we felt it was important to make sure that others that are in the community could look at these documents. So we asked 6 experts to give us their opinion about the document. This vision of KCP was to have a comprehensive core set of strategic recommendations. These recommendations were based upon a strong contextual and organizing framework that we felt need to resonate amongst ourselves, amongst the community, with CMS and other important entities. We followed the National Quality Strategies format and put together a comprehensive list of domains and subdomains to improve kidney care quality. There are actually 9 domains and multiple subdomains. Importantly, we looked at what the goals need to be to ensure or attain kidney care quality. And then congruent with the NQS, we developed drivers of transformation. These are basically effective mechanisms that can drive change as we go through the various domains to achieve our quality outcomes. You will hear about our strategic opportunities. These are key recommendations that, if followed, can improve care delivery. And importantly, we identified key barriers. And this is critical because these are necessary to identify to ensure that the success can occur within each domain as we utilize the drivers of transformation. And I'd like to turn this over now to Gail Wick. Gail?
After determining that the contextual and organizing framework of the blueprint would be based on the National Quality Strategy, goals to address the aims and priorities of the NQS were identified for our patients with late-stage CKD or ESRD. And those 4 goals are improved survival, reduced hospitalizations, improved quality of care, and improved patient experience of care. These are goals that are not dissimilar to healthcare goals nationwide. Next slide, please. Thanks. Once the goals for kidney care were identified and agreed on, the focus shifted to identifying aspects of care that can positively impact one and preferably more of the goals. And as Ed said, with input from multiple stakeholders at various times, 9 primary domains of care, many with subdomains, were ultimately identified. All of them are shown on this slide as well as in Table 1 of the blueprint. The primary level domains or aspects of care are care coordination, disease management, infrastructure, palliative and end-of-life care, patient engagement and education, patient satisfaction and experience with care, pediatric-specific issues, quality of care, and last but definitely not least, safety. It's fair to say that some of these domains have received more attention and improvement than others in the past, but all have been deemed key aspects to address and improve going forward. Next slide, please. With the goals and key care domains related to kidney care quality identified and accepted, focus then shifted on how best to affect change that will translate into meaningful improvement. In other words, what do we do to affect and then sustain improvement? What will drive us toward the goals if we appropriately apply them to the domains? 5 transformation drivers, as they are called, were then identified by KCP for kidney care quality, and they're shown on this slide. With respect to the federal government's QIP, as you know, various programs such as the USRDS Annual Report, Dialysis Facility Compare, and the DOMPS program have long reported longitudinal information about kidney care quality. But most recently, the QIP has garnered a lot of attention, and in fact, some would say most of the attention. It encompasses public reporting and a penalty-based program and has actually provided a solid foundation for improving quality, and it continues to be an important driver of quality. But however, as you'll see when you go through the blueprint and you listen to the rest of this presentation, it's only one of a number of potential drivers. So as one considers the QIP going forward, several key questions need to be addressed to most effectively drive quality. And these questions are thought to be: 1, what measures currently exist and should be included for key domains? 2, are there evidence-based high-leverage opportunities that exist but still need appropriate measure development? And 3, what's the best, most appropriate, and transparent way to address measures? The blueprint will help guide us in answering these questions as we go forward. Internal quality improvement, or IQI, is the next driver of transformation that was identified. IQI refers to internal quality-focused activities that many, if not all of us, do within our individual organizations. And there's general consensus throughout the healthcare community that IQI initiatives can be very effective drivers of transformation, and numerous thoughts on their use are actually provided in the blueprint. A few examples of IQI that readily come to mind include standardized protocols, identification, use and dissemination of best practices, as well as benchmarking, and many of us are familiar with those activities already. From a research perspective, it goes without saying that new knowledge and its dissemination are essential to improving care and outcomes. And research findings lend themselves really well to both external and internal quality improvement programs. And with respect to research, the blueprint's focus is on specific knowledge gaps where research is felt to be able to advance understanding of a domain and would thus then drive a significant improvement in one or more of the goals. Federal policy and, to a lesser extent, state policy affects care delivery and is thus an important driver of healthcare quality. And because Medicare is the primary payer of kidney care, federal policy's impact on kidney care quality is particularly important. And the blueprint addresses various policies that are felt where it would be reasonably eliminated or modified in order to improve quality. And last is system innovation, another important driver. And innovation, as used here, refers to potential system delivery changes, potential technological advantages, or potential policy changes that can be explored through small-scale projects or testing if they seem promising for improving quality before they're put forth into prime time, if you will. Next slide, please. So in summary, applying these drivers of transformation that I've just reviewed, QIP, IQI, research, innovation, and policy, to those 9 key aspects or domains of care with their subdomains that have been identified to date and others will continue to be identified, will facilitate improvement and subsequently the achievement of the 4 quality goals that have been identified for our patient population: improved survival, lower hospitalizations, improved quality of care, and improved patient experience of care. And with that said, I'll turn it over to Alan, who will discuss the strategic opportunities within each driver of transformation. Alan?
A little more color, 5 drivers of transformation that Gail just talked about. First, let's start with the QIP. As Gail has said, we really believe that the QIP has been an extremely valuable tool that has been developed in close collaboration between the renal community and CMS, and that it's really helped create the foundation for improving outcomes for patients with end-stage renal disease. But there are 4 specific areas outlined in the blueprint where we think QIP could be strengthened based on the 9 domains identified. One is to look at the whole measure development process and the rigor with which measures are developed. Second, to make sure measures are harmonized, since there are more and more measures coming from lots of different places that overlap within the domains, and this can be very confusing and disconcerting for patients as well as caregivers. Third, and one that's very granular, relates to vascular access care for patients on dialysis. The vascular access is really the Achilles heel for the treatment of hemodialysis patients, and the inclusion of artificial grafts in the QIP to incentivize the use of either these forms of access or natural arterial venous fistulas rather than catheters. The so-called catheter-last approach is something we think would be helpful. And then finally, looking carefully at the CAP survey, which is the current quality of life survey, to make sure that that truly can help drive improved outcomes. So we think these could help in improving QIP. The second driver of transformation is internal quality improvement. And as Gail mentioned, these are activities that are currently ongoing within various parts of the kidney care community. And the blueprint outlines 14 specific areas where internal quality improvement could be focused by caregivers, any of which, if tackled well, could improve care, and covers a broad range from very specific things like vascular access to much broader clinical issues like fluid management, nutrition management, the avoidance of infections, managing comorbid conditions like diabetes, hypertension, and heart disease, addressing depression, medication management, and so on. So the blueprint outlines a menu of these internal quality improvement topics that any one of which, if improved, would improve overall outcomes for patients. The third area the transformation driver is research, and it's clear that there are gaps in our knowledge about what the best approach to a whole variety of clinical areas for ESRD patients exists. So the blueprint outlines a series of areas where more research would be extremely helpful to increase the understanding of the current state of the art and where there are opportunities to improve. So areas such as management of bone and mineral metabolism, management of fluids, efforts to reduce hospitalizations by a better understanding of why hospitalizations and rehospitalizations occur. There is an important phenomenon of sudden death that occurs in these patients, often on Mondays and Tuesdays during the long interdialytic interval, the time between treatments, and understanding that better would be extremely helpful. Better understanding of how to measure and improve quality of life and how to engage patients are all areas for future research that could help improve outcomes. The fourth area of transformation driver that is detailed in the blueprint relates to system innovation, and the concept here is by looking at care delivery and how the whole system of care might be revised, rethought, or improved, could drive significant improvements in the primary outcomes that Gail and Ed mentioned. So the particular focus articulated in the blueprint includes looking at integrated care, so holistic care with the patient in the center, so-called patient-centric care, and all of the healthcare needs being coordinated by the healthcare team. In addition, a focus on alternative dialysis strategies. The majority of patients in the U.S. are on in-center hemodialysis. More and more are going home on peritoneal dialysis or home hemodialysis, but exploring these alternatives and others is another area where we believe there could be significant care improvements. And finally, the fifth area, which is public policy. The ESRD program is the only disease-based entitlement in Medicare. As such, there's extensive public policy oversight of the care of kidney patients. So there are a number of policy areas articulated in the blueprint where we feel there could be improvements in policy that would help drive improvements in care. So things like supporting the advancement of quality in the delivery of care, so providing support to allow innovation, to provide incentive payments in QIP, as is done in other incentive payment programs, that is rewarding good performance, not just punishing less good performance. There is a need for encouragement for health information exchange, particularly as we go into coordinated and integrated care, and a way to incorporate new technology into the payment system, which is currently extremely difficult. And with that, I'll turn it back over to Ed.